Okay, I'm Gwon from Samsung Medical Center, and I am the second operator is Sang Lee from Jungang University, Gwangmyeong Hospital, and we have a third-year fellowship trainee, Onyu Kim. Okay, Dr. Lee, you present today's case.
Good morning, everyone. My name is Onyu Kim, and I will presenting the live case of calcified coronary lesion. Next. This is a 71-year-old man who has been experiencing the ejection chest pain for about 1 year. His past medical history includes the hypertension and hyperlipidemia. And in outside hospital, coronary angiography was performed. The PCI of distal RCA was successful, but the wiring failed in the heavily calcified lesion left main to proximal LAD. Next. The electrocardiogram showed the normal sinus rhythm. Next. The echocardiography revealed the normal LV systolic function without regional wall motion abnormality. Next. The coronary CT angiography confirmed the severe calcification from left main to proximal LAD. Next. So in the outside hospital, there is the significant stenosis at the distal RCA, and RCA PCI was performed successfully. Next. The severe calcification was noted in the site of the significant stenosis extending from left main to proximal LAD. Next. But the wiring failed from LAD to proximal LAD lesion. Next. These are our discussion points. First, how to achieving the successful wiring in the calcified lesion. Second, what is the best strategy for calcium modification in the left main to proximal LAD large vessel. Third, the necessity of the intravascular image guidance.
Okay, thank you, Dr. Kim. As you can see here, you can see a heavy calcification and in the almost at the left main bifurcation or LAD also to proximal LAD. And next, so we are considering the rotablation and IVL lithotripsy because there is no very large study comparing the IVL versus ballooning or cutting balloon. But this year, ECS, the Bali trial was presented. Enrolled only 200 patients, but they compared IVL versus conventional treatment and the free use of rotablation. Actually, in the IVL group, rotablation was used in 31%. Then the IVL was proved to be better than conventional treatment. So this is a very tight LAD lesion. And I'll show today's angiography. And right coronary, can you see? Yeah, switch to the angiogram, please. Angiogram. Okay, this is RCA. The stent is well put, a little bit underexpanded in the middle of the stent. Right, there's another heavy calcification there. And next. So initially we used the 7 French guiding catheter because the calcific burden is very high and even IVL cannot overcome the thickness of calcium. And yesterday I learned from Dr. Ziad Ali that the calcium thickness is more than 1 millimeter. And sometimes IVL is not so effective to fracture the calcium. So maybe we need a 1.75 bore, but I chose 7 French guiding catheter. But we have pressure dampening, so that I can get the guiding catheter deep into the LAD. So I'll switch to 6 French. This is a 6 French XB 3.5. This is a epicaudal view. You can see a huge calcification burden in proximal LAD. And next, and spider view. It looks like the eccentric calcium, but you can see the calcific line in each side of the vessel and 2 orthogonal view. That means we have the encircling calcium plus the calcific nodule inside of it. So this is very tough case for rotablation and IVL. So how do you think?
Thank you very much for your nice presentation. Open for discussion.
고정규.
So while we are talking to each other, please go ahead, your procedure.
Okay. So, but so far, let me explain the procedure so far. So wiring is quite challenging, I think. So next. Yeah, I use the microcatheter with a run-through wire to challenge the wiring, the proximal LED. Yeah. Actually, previous failure was done because the wire is coming through the plate. So I meticulously analyze the angiogram and have a good target. And next. And got through the LED. Then next. But the wire doesn't come into the LED. So I put the guide wire in the diagonal and try to push the microcatheter, but failed. Microcatheter cannot be crossed to the diagonal even. Next. So I have no choice but to bare wire, bare rota wire wiring and to the LED. It's quite not that difficult than I expected, right? It took over less than a minute. Next. So we successfully exchanged to a rota wire. Okay, maybe you can discuss and I will do the procedure. This is 1.5 bar Rota Pro. This is a typical test ablation for me. So there is no hemodynamic compromise after a very short ablation. So I am convinced to proceed without any hemodynamic compromise. But actually, aminophylline is prepared. If there is BP drop, bradycardia will give the aminophylline immediately to the patient. Okay, I do the procedure.
My protocol is just infuse 1 ampere of atropine through the coronary artery just before ablation. That prevents bradycardia.
I prefer aminophylline to atropine because atropine makes tachycardia and the patient uncomfortable and make ischemic. The aminophylline actually tachycardia is not so dramatic, so I prefer aminophylline.
But atropine just blocks sympathetic tone. Thus, if the patient's sympathetic tone is very high, it may induce tachycardia. But vagal tone is enough, then we don't see such kind of tachycardia after intracoronary infusion of 1 ampere of atropine.
Okay. Any discussion from panels? Do we need the rotablation plus IVL is enough for this very huge calcification? Sometimes even after the rotablation IVL, we have the underexpanded stent. So what I was told yesterday is more than 1 millimeter of a calcific thickness. IVL is frequently failed to make a fracture, so try to thin a calcification up to 1 millimeter. I'm not sure for this case. In which one side is more than 2 millimeter, maybe? Yeah.
Under current Korean reimbursement criteria, we can use burr, 2 kinds of burr. So first burr is 1.25, and then 1.5 or 1.75. Then we don't need IVL. Thus, if we start rotablator, then do rotablate first, and NC ballooning, if it is fully expanded, then we can save IBL.
I think to decide next procedure, imaging information is very important. Current situation, imaging device is impossible to pass through this calcified region. And after this rotablation, and check OCT or IBS, and decide next best additional subsequent procedure, I think.
네. 뒤에 좀 잡아줘요. 네, 띄우고. 오케이. on. 네, 보세요.
So, which imaging modalities is more appropriate for these calcified lesions between OCT or IVUS?
Of course, everyone knows IVUS cannot judge depth of calcium. So usually in this kind of situation, the OCT is, I think, more common. I think.
제가 하고.
I agree with you. Yeah. OCT definitely better than IVUS in calcified lesion.
But how about in the left main, very large vessel? Maybe IVUS have some advantage.
But this is not left main, just proximal LAD. I think OCT may cover the vessel.
Yeah, personal preference maybe. I think actually OCT is used in other room. I have to use the IVUS.
Okay.
The person scientific prepared 6 French IVUS catheter recently. Its profile is larger, but very easy to flush. The low risk of air embolization of air. They prevent us to have a very nice image of the IVUS. Anyway, you need to have an angiography first. Angio?
Actually, IVUS is not so bad because most important information is arch of calcium, round calcium, or eccentric calcium. Such information is we can acquire from IVUS finding. So, not so bad.
Yeah, we made a hole.
Okay, all right.
This is the Avigo system. You can see, as you know, that we can have OCT-like imaging techniques for. 잠깐만. 와이어를 가는 게 낫겠다. 네.
마이크 같았다.
Firstly, no. Run through wire 좀 줍시다. Firstly, I exchange to wire.
Avigo system use 40 megahertz detector. There's resolution significantly improved. Probably lateral resolution maybe about 20 to 40 micron. Of course, it did not reach the resolution of OCT, but the resolution improved between OCT versus traditional IVUS. And we can regulate the pullback speed, usually 1 millimeter per second. But with this system, we can increase the pullback speed up to 4 millimeters per second or 8 millimeters per second. Thus, we can reduce the procedure time or ischemic time in critical stenosis.
Epicranial. After rotablation, I don't use a microcatheter because it should be very easy to cross the wire. Okay, LED. Yeah, I like to prolapse the wire here. No, not that. Not prolapsed. Yeah. Okay, that's okay.
Dr. Gwon used run-through. It's very old-fashioned wire. How do you think about the wire usage, Dr. Igarashi? I gave up run through many years ago. I always use Seoul as a standard wire, but some guys in Korea still maintain usage of run through. How do you think about such kind of behavior?
Okay.
Behavior.
Yes, okay. So, workhorse wire is.
Antisocial?
I think one choice. This run-through wire is very, very nice wire. And this shape is very easy and some advantage. So in Japan also, still many operator use this wire as a workhorse wire.
How about you? Do you use
My daily practice Xion blue or Xion, and this case is maybe I will use Xion because Xion is more slippery.
or Seoul black?
Xion black is one choice. However,
좀 잡아줘.
Xion black is sometimes easily go deeply distal part and make some perforation or something. So in some special case, I select Xion black.
1mm 했으면 좋겠는데, 1mm? 네? 오케이. 아이브 스크린 올려주시고요.
Media lady.
Yeah, middle lady. Here.
화장해.
Okay. Okay. I prefer to use the 1 millimeter pullback actually myself. It's a 3.0 vessel, lumen 2.0, eccentric calcium. Yeah, it is medial lady lesion. Encircling calcium. Distal to diagonal actually. And not getting better. This is diagonal. This is side 3.5 eccentric. Another diagonal. Yeah, encircling calcium. There is a reverberation, very difficult to evaluate the vessel size, but still around the 3.5 encircling calcium. This is circumflex. And the plaque is going across the left main. That's why you had pressure dampening with the 7 French guiding catheter. Okay. The problem is that actually I have some resistance to push the guiding IVS catheter in the medial lady just above the second diagonal. I'm not sure the IVL catheter is go very easily or not. Some of the panels want some balloon dilatation before the IVL catheter insertion.
Yeah, if you do not use a rotablator, usually they recommend NC balloon inflation before introduction of IVL balloon, usually 2.0 NC balloon. But you did rotablation with 1 to 5 burr.
Yeah.
You may need NC ballooning or not. How do you do?
Yeah, that was my question, not your question. I asked first.
I think
Usually I don't use another ballooning after rotablation because after rotablation, usually I don't have any resistance to push the IVL catheter. But in this case, I had a resistance. Is it safe to try push hard the IVL catheter because it's a very low pressure balloon, very easy to break?
I suggest you to choose 2.0 or 2.5 NC balloon. If you use 2.5 NC balloon and it is well expanded, you can save IVL. Or not, you have to do IVL.
Do we need a cutting balloon?
Cutting balloon, is it possible to introduce cutting balloon?
I'm not sure.
It is more...
Okay, NC balloon 2.5 or 2.0?
I prefer
2.0 is better?
2.5. I prefer 2.5
I
because you already rotablation.
Okay, 2.5. And
I think
balloon
proximal
training.
very narrow part is not round curve. Some part is already crack or something is detected.
Yeah.
So maybe possible to dilate. However, indentation is remaining. Some additional modification is maybe necessary. And I think one
Actually-
choice is bar size up is one option. However,
Yeah.
this case is a French guiding catheter is selected, so maximum bar size is limited.
Yeah, I think that the upsize the burr for the at least for the proximal LED up to 175, I think is necessary since that the
Right,
vessel is quite huge and it's quite difficult to push the IVUS caster. So I think just only for 1.5 burr to debug the proximal LED is not enough. I personally agree.
That's my initial plan. Upsize the burr into 1.75 burr. Actually, but the guiding catheter is damped in the ostium left main because the left main is diseased. So for the safety, I chose the 6 French guiding catheter. So definitely I agree with you. 1.75 burr is needed even before IVL, but not in this case.
I think it is too wasteful. 2 burr plus IVL, I don't agree.
Okay. So yesterday I learned from Dr. Ziad Ali that the balloon 2.5 NC balloon test the severity or the hardness of calcium, especially in the calcium nodule. I'm not sure this is a case for the balloon test, but he said he routinely uses a balloon test for. Anyway, I'll give an idea that how hard is the plaque. Okay, start. 8 atmosphere.
As you know, we in Korea, cutting balloon is not available for not covered by insurance
10,
for the
10,
native calcified
14,
lesions. So
14.
and the passage is quite hard. So maybe NC balloon first and seeing the
Inflation?
responses.
또 올라가야
I
되는구나.
think.
Rotablator, NC balloon, IVL.
Yeah, 8. Sometimes we need
don't agree,
everything. 10, 12, 12. I don't like to overinflate the vessel because the vessel is 3.0. Deflate.
Why did you choose such a long NC balloon?
As we discussed before, long NC balloon, short NC balloon, the dilatation power is the same. It's a law of Laplace. Maybe we can discuss about that.
But we
Inflation?
we can see the dog boning phenomenon. There's certain part, very hard part, may not be expanded with long limb.
14. I don't like to go to a very high pressure with the NC balloon because we are planning to have use IVL. It's deflation. 8-quarter.
This region has multiple side branch, but the operator do anything for the protection of side branch occlusion.
That's my user practice actually. Inflation. 14. 14 atmosphere. Still, the distal part of the balloon is not well expanded. 18. 18. Yeah, not well expanded. Okay, deflation. So side branch actually. I think the most important predictor of a side branch compromise is oversizing the stent. The wire protection is some studies show that the wire protected the side branch, some studies showed no protection. So it's quite unpredictable. So the ostium of plaque burden is very important, but plaque burden in the main or side branch in the two diagonals are not so high. So, and I like to control the pressure and the stent expansion to avoid the side branch compromise. It's not recommended by EDC, as you know. This is my practice. Okay? IVL 해봅시다. 엔조하고.
So according to this AP caudal view,
IVL 준비해달라.
already posterior area has a large plaque burden is close to the circumflex opening side. So it is high risk for the jailing of a circumflex after left main crossover stenting. So as Dr. Igarashi mentioned that if possible, it will be better to debulking more, especially the austere part of LAD using the wire bias technique.
Yeah. You have seen a lot of bifurcation procedure with wire protection. So 3.0. And maybe you can enjoy the bifurcation intervention without wire, and you can see. If I fail, do you like it?
휘파로 설명한 거 보여드리고
앞쪽으로.
Usually, the calcific nodule is lateral side, opposite to the circumflex ostium. But there's no chance circuit obstruction by calcific lesion. But there is a more chronic shift toward circ due to the hard calcific nodule lateral side. This carotid movement may be, carotid shift may be more aggravated. But Dr. Gwon, based on his many experience, he is sure that circ obstruction risk is very low.
From the spider view, I can see a dissection austere LAD, and maybe in that case, that could be extended to the left main. So maybe if it is available, the wire protection could be better, I think.
Really, dissection is detected? Spider view?
Spider view.
Okay.
Have you seen the dissection in the spider view?
He did not took
I'm not sure.
spider view after rotablation.
Okay.
Just he did areocaudal view. Can you see? Can you show us the previous angiogram?
Yeah, previous angio, spider. Good.
Angio.
Yeah,
Okay.
this one?
Yeah. We don't see this dissection.
Yeah, I think so.
Just
좀 이따 하고 이거 해야
specification due to calcific nodule.
카메라 여기 좀 비춰주세요.
Maybe I think so. However, examination of iris is
has a
여기
heavy
보여달라고.
calcified burden, especially for the close to the circumflex opening side.
더 낮추라고.
If we use stenting, the calcium can move to the circumflex side.
됐어. 오케이. 여기 있구나. 오케이.
When I'm looking at this region, this has a Medina 111. So should we think about the two-stent strategy for the left circumflex?
백킹. 왜 밀고 가?
I never recommend a two-stent strategy. This kind of case and stent full expansion is definitely impossible. And under such a condition, a two-stent strategy and the future restenosis or thrombosis risk is very high, I think. So maybe in this case is impossible to get final optimal result because of very, very heavy calcium. So anyway, calcium volume reduction is very important in this kind of situation, and additional bar size up, and I think maybe avoid stenting, and DCB treatment is very safe to keep preservation of circumflex patency is, I think, one option to stop to finish this PCI, I think.
I think the best strategy, provisional strategy, just cross over one stenting and see the circle ostium. If it is very compromised, then we do DCB and final kissing balloon.
Okay, I partially agree. because LAD, left main crossover circumflex LAD stenting is optimal. Expansion is possible. One stent thoracic is possible. Best. However, I doubt very difficult to get optimal stenting to LAD, left main to LAD, I think.
Okay, 연결합시다.
So anyway, very challenging case.
Dr. Gwon, which size of IVA balloon? 3.0?
3.0.
3.0, okay.
3.5 may be good with a lower pressure, but contact is important. So lumen size is less than 3.0, so I prefer to use a 3.0. But 3.5 with a low pressure is acceptable. And the balloon preparation is very important because very easy to break. And the air is inside of IVL, the energy transmission is stopped with the air. So we meticulously prepare the air with 3 times negative pressure. Okay?
Dr. Gwon, we have to move to the second room. Is it okay for you?
Yeah, okay.
Okay.
You have seen the IVL procedure before, so it's boring. Let me show, just to show the crossing of the balloon catheter just in 30 seconds. Okay, 와이어 잡으시고.
Are you going to use all 120 pulse?
Yeah, of course.
Which area are you focusing?
The main, of course, but I try several pulses in the middle AD too. Yeah, let's.
How many segments? About
all the segments
3 or
possible.
4 segments? Use 120.
좀 잡으시고. 와이어 넣고. Okay. It was easy to going through the proximal LED, but this time still some difficulties. 파이팅 잡고. Maybe we need to use the side extension for this lesion. Okay. 가이드라인 하나 주세요.
Even though he used 2.5 NC balloon,
so,
the advancement get difficulty because he just did not use maximum pressure to use IVL. But if NC balloon shows indentation, finally NC balloon, IVL balloon advance is hindered. Thus, my personal view is if you use NC balloon before IVL, you have to remove the indentation by high pressure. He used extension guiding catheter to improve the backup and try to advance IVL balloon. And after seeing the first segment pulse delivery, then we are going to move to the second room.
Okay. 저거 IVL.
C2 Plus version provide 120 pulses. Original version provide 80 pulses. Thus improved. So we can deliver more shot. Thus we can cover longer target calcified lesion.
Okay. 가이딩 잡아주시고 임원유생. Okay, then. 잠깐. 가이딩 정렬 잡고. And push the wire as deep as possible. Then push the Godzilla. Okay, let's see. Okay,
passed.
Over here, maybe I start 10 or 20 pulses. Okay, 김원효
Then withdraw the extension guiding catheter because
얼마죠?
Coronary pressure is...
Okay. 하기야? Quite much. Oh, sorry. This is live, so I'm past. Okay, here maybe the first one. Geisler. Okay.
Okay.
Okay, inflation, 4 atmosphere. Okay. Yeah, I give the pulse.
How many pulses for this segment?
I planning 20.
20.
Okay. Deflation?
But
Too many?
no, 30. How about 30?
30.
Yeah,
really?
because this lesion has encircling calcium. It's very hard to pass through.
Okay. Yeah, same place. Inflate 4. 4. Yeah.
To target long segment, calcified segment, we plan to how many segment should be treated.
Deflate.
If the lesion has irregular, in some part heavily calcified, in some part less calcified, then we can adjust
Okay.
pulse
A little
number
bit
in
move
each
a bit
segment.
personally. Inflate. 4. Okay. I'm giving the pulse.
So he is now delivering the same 20
Yeah.
pulses for each segment.
Okay, deflate. I prefer to use as many pulses in the proximally. So I gave 30 pulses here, move to here, a little bit more. 4. Okay.
How many pulses for this segment?
I'm calculating.
More than 30?
30, just deflate. 가슴 아프세요? 괜찮아요? 괜찮죠? 오케이, 좋습니다. 약간, 오케이. Inflate.
Since there is
Vital
the
stable.
collateral flow from RCA to LAD, so I think the procedure is very safe if he occluded the LAD as long as possible.
Okay, deflate.
Dr. Gwon, we are back.
Yeah, well, I put the stand, and I'm about to examine with the IBIS. 이게 안 들어가나? Okay. So, previous 엔지오 좀 보여주세요. 멘탈 때부터. Yeah, I applied 40 pulses in mid LED and 8 pulses in the proximal LED, mostly focused on the LED ostium. And next. This is angiogram. The lumen is widened. I can see the significant dissection. Next. The epicranial lesion is improved. Okay, next. IBIS, please.
At this time, he did IBIS examination.
No. IBIS 안 했지 아직. Yeah. And IBIS. IBIS on the screen, please.
Let's see the change of calcified plaque after rotablation plus IVL.
Okay, play. 풀백 속도는 빠르게 되는데. Actually, I used the 8mm rapid pullback system, and I will play in 1mm. 더 밑으로. 더 밑에서, 제일 밑에서 1mm 속도로 1mm replay. Okay. So I use the both system, but I prefer to use a simultaneous 1mm pullback and intermittent angiography with where is the IVUS is looking at, checking the location. That's more preferable for me. So you can see some breakage of the calcium, but we are not sure this is because of IVL or NC balloon. Anyway, the data show that the fracture number is not related to stent expansion. So I believe in mind that there is a lot of fine cracking inside of calcification. That crack, you can see a lot of cracks in the calcium.
We saw 1 point of stenosis. Can we see it again?
Stenosis?
One stenotic point on IVUS. Can you see that focused segment once again?
Can you find it?
It looks very strange, but partially. Yes, I agree.
Proximally and distally.
Maybe mid of proximal region. Yeah. So this transition.
This is left main. The proximal LED 다시 좀 찾아봐봐요. 아니, proximally.
Yes.
Proximally. Here?
Just this.
Here.
Yes, sir.
What's this? Yeah.
Shadow. I'm not sure. This is air. Maybe artifact. I'm not sure. Okay, I just put the stent angiography on the screen, please. Angiography. Okay, I put the 3 millimeter, 40 millimeter in length, 3 by 40 oscilloscope stent from the LED to proximally. I inflated with 10 atmosphere, just 10 atmosphere. Next. And pulled back a little bit, and 14 atmosphere, pull back, down, next. And next stent is positioning is very important. So I checked the LA view to looking at the ostium of the left main. Next. As the next stent was 3.5, 26 oscilloscope stent. Next. And I'm checking overlap. Next. Yeah, we already checked the ostium in the LA view, and I inflated with 14 atmosphere. Next. And dip down and 14 again. Next. And the pull back 18. Next. And use the 4.5 12 millimeter NC balloon and part for the left main, according to the IVUS size. Next. This is endurance. You can see some narrowing distal to second diagonal. I'm not sure. Next. Actually, this is very difficult to examine all the residual stenosis in the angiography. That's why I use the IVUS to find the narrowing. So actually now we are trying to give the IVUS catheter inside of it.
Why didn't you cover the left main ostium with stent? The stent proximal edge is just mid-body, and the dye image
actually,
is
I will show the plaque in the left main ostium. That's why guiding catheter was stamped. I found the plaque in the left main ostium. So if you start in the middle, maybe it's kind of
you did cover left main.
Yeah, I covered the left main. You prefer just the LED ostial coverage?
No. Because the previous angio looks awkward because there is some step at the mid left main body. Thus, I noticed that was proximal end of proximal edge of stent.
overlap 된 거? So actually, okay, I had a difficulty in pushing the iris catheter into the LED stent. Actually, this is the 6-French iris catheter, so Geisler, if you use a Geisler support, the iris catheter can go through. This is a limitation of a 6-French iris catheter. So option is I dilate again.
I prefer NC post-ballooning first before advancing extension guiding catheter.
Right. Yeah.
It may
That's
destroy
what I'm going to do. Actually, you can see your first diagonal is shadowed by the stent. The flow is okay, but the overexpansion at this location will compromise the circumflex with or without protection wire in the diagonal artery. So I have to control the pressure to avoid side branch compromise and also enough expansion. I start from the above the second diagonal test.
Most panels concerned about the possibility of circ obstruction, but circ flow is maintained.
Yeah. And 14. Yeah. Deflation. 에피코드 좀 보볼래? 아까 엔저 찍은 거. 서컴플렉스가 아직 돌리지 말고. Yeah. Okay.
Here, see the mid body of left main.
Epicaudal view.
Dr. Gwon?
Yeah.
Can you repeat caudal view, angio?
Yeah. caudal angio 좀 보여주세요.
Audio caudal view. Yeah.
Okay.
Here, at mid body, there is some minor dissection like difilling, lower part of mid body. Thus, I recognize that is proximal edge of stent, but you covered stent until ostium of left main. Okay.
Yeah, let's see with
let's
IVUS
check it
then.
through
Yeah.
IVUS. Okay.
다시 플레이 좀 해보세요. And there is a residual stenosis in the above the first diagonal. That's what I'm doing. Post inflation. 12 implant. 12 달라고 그랬는데. I ordered the 12 millimeter NC balloon, but we don't have now, so it's 15. Too long test. 조금 더 들어가야겠다. Too long NC balloon actually.
But some part of balloon may be inside the guiding catheter. No problem.
Yeah, test. Okay, inflation. And 14. 18. How about this? Yeah, a little bit underexpanded in the middle of the calcification deflation. I think this is the best we can do.
Is it 3.5?
3.5, 15. Angel? Sure. And after IVUS, we'll find what should be done further.
In this view, you also some awkward finding at mid left main body.
Yeah. This is, I'm not sure this is branch or this. 첫 번째 엔지오 좀 보여줄래요? The first, give me the first apicaudal. Yeah, it was not there. Okay, flushing. 네, 닫고.
Okay, final IVUS.
Yeah.
Because we have just 2 minutes.
I hope. But if there is a significant residual stenosis, I can use still. Oh, catheter tip is not going in, right? That's sometimes it happens.
Just withdraw wire a little bit to change the direction,
Angle.
coaxial tip.
Or guiding.
Yeah. Or to and fro, trial.
Yeah. It is stuck in the second diagonal level.
Okay.
Maybe we can change to 1.5 French ibis catheter and use the. Okay. That's fine. Okay. Yeah. Change the location of the guiding catheter, wire, and it goes through. Okay. 1mm will be. Okay. This time. Okay. Okay. This expansion is okay. Good thing about simultaneous pullback is you can see where is the ibis catheter is. Now it's okay. Eccentric calcification, a little bit elliptical, but still expansion is okay. This is around the second diagonal. Yeah, quite circular and well expanded. Between first and second diagonal.
MLD is more.
From now on, this is a very heavy calcified plaque lesion.
MLD is 3 or more.
Yeah. I pull out the guiding catheter a little bit more. Yeah, expansion is okay, right?
Yes.
Okay, covering almost the ostium, right?
Wonderful.
So I'm not sure what is the funny slip dye staining, but it doesn't seem to be a serious problem.
Okay, we have to move to the Dr. Song again.
Yeah.
Okay, thank you very much for your wonderful presentation, ROTA plus idea.
Thank you.